recording.
I've started.
Okay.
Okay. So, yeah,
Okay.
okay. So good evening, senior colleagues. Okay, good evening, senior colleagues and colleagues. Dr. Jeremiah will be taking us today on catecholaminergic polymorphic ventricular tachycardia. Dr. Jeremiah, you can please have the floor. Thank you.
Thank you very much. Good evening, my teachers, colleagues. I will be taking the topic catecholaminergic polymorphic ventricular tachycardia. And I'll start with, okay, sorry, I was supposed to have an outline before this, but I'll start with the historical perspective. Catecholaminergic polymorphic ventricular tachycardia is a genetically inherited arrhythmogenic disorder that has garnered significant attention since its initial identification in the 1970s. It was described first by Red et al. In 1975, and it was recognized as a syndrome characterized by exercise-induced syncope and sudden cardiac death in individuals with structurally normal hearts. The pivotal moment, however, was in 2001 when mutations in the ranudin receptors gene were identified as a primary cause of the condition. In the years following that, other genetic causes were also, mutation were also identified. That include the calciquitrin gene that is present in the cytosol. The epidemiology is that is a significant cause of sudden cardiac death, especially in young individuals. In fact, it's particularly in children and adolescents, and is approximately 1 in 10,000 individuals, with a notable incidence in population with family history of arrhythmias. The condition is often underdiagnosed because of its asymptomatic nature during rest. And usually during rest, the ECG appears normal when the patient is not under stress. So demographically, it predominates among children and adolescents, and the onset is reported to be around 10 years. The condition is more prevalent in male than female, although the exact ratio across differs among studies. This can be explained by hormonal influences on cardiac ion channels and channel function, which predispose male to higher risks of arrhythmias during adrenergic stimulation. Familiar patterns have been identified because of that is as related to the mutation. The ranudin receptor 2 account for about 60% of cases, while the calciquitrin 2 gene mutation account for about 30% of those cases. Further genetic screening led to the identification of other genes, such as the CAM1, CAM2, and the KCNJ2, which also exhibit autosomal dominant inheritance, just like the ranudin 2. Familiar clustering have been documented, and the identification of this mutation has significant implications for family screening, such that if a patient is suspected to have that and confirmed, if family screening is ensured to take appropriate steps. The pathophysiology of CPVD, I just put this there to remind us of a normal, remembering that the cardiac action potential, looking at here, I don't know if you can see my pointer, looking at this is the membrane of the cardiac myocyte membrane, then this is the intracellular area, then this is the extracellular area. Remembering that potassium ion, the concentration is high intracellularly, while sodium is high that is extracellularly. Now, because of the presence of negatively charged protein within these cells, and also there's this sodium potassium ATP pump that maintains the concentration between these two ions, such that 3 ions of sodium is going out, coming out, and 2 of potassium is coming in. So if you can see, so three going out, 2 coming in. So the end result is that the inside, the internal aspect of the membrane is negatively charged, while the external is positively charged. So that difference gives you an electrochemical gradient, and in the normal gradients between the two, that is the difference. The difference between that is normally between -70 to -80 millivolts. So action potential is generated whenever there is increase in the positivity of the intracellular parts of the membrane. So once there's increase in positivity, meaning from -80 and going down, okay, look at the diagram here, we have -80. Then if the positivity increases up to about +90, up to about +20, that, okay. Now, okay, just to relate with this, remember the first one is when there's action potential, when there is depolarization, meaning, for instance, we're talking about the transmission of impulse from the we're talking about the transmission of impulse. So when impulse is transmitted for the pacemaker, the electrical impulse come over to the cardiac myocyte. We're talking of the cardiac myocyte now, not the cells in the nodal area. Now, by the coming of the electrical impulse, there is depolarization. The depolarization leads to the opening of the voltage-gated channels, which allow the entrance of sodium ion. The entrance of sodium ion reduces the negativity, the intracellular negativity, and so it reaches a threshold potential, and so action potential is being generated. So phase 1, phase 0 represent that depolarization. At phase 1, it comes to a peak, and repolarization commences. Then phase 2, we have a plateau, which is maintained by the sodium-calcium exchange channel. And then we have phase 3, which lead to the depolarization, and then back to the resting membrane potential. So the cardiac myocytes, they differ in cellular structure from other cells, but depolarization causes calcium ions to enter the myocyte via L-type voltage-gated channel 1. Just to go back, at this point, this sharp depolarization is usually caused by the opening of sodium voltage-gated sodium channel. But when it gets to like -35, at that point also there is the opening of the L-type calcium channels, and so that also the influx of calcium also leads to auto add to the depolarization. But the influx of calcium leads to the activation of the calcium-sensitive calcium release channel, also known as the ranodine receptors, in the cytoplasmic reticulum, which causes sufficient flooding of the calcium ion to initiate contraction. So we know of this, the calcium ion now bound to the troponin C, exposing the actin binding site, while the myosin then bind to actin, and contraction occurs via the actin-myosin interaction. secondary to hydrolysis of the adenosine triphosphate. As relaxation of the myocyte commences, calcium ions disengages from the troponin binding site and are actively transported out of the cytosol. I just made mention of this for us to have an understanding of the pathophysiology, but under normal physiologic condition, catecholamines such as epinephrine and non-epinephrine, they bind to beta adrenergic receptors on cardiac myocyte, and that leads to an increase in intracellular calcium level, which enhances the cardiac contractility just by this mechanism we have described now. So the increase calcium causes the calcium-sensitive calcium release channel to release more calcium, and that leads to the cascade of activity leading to contraction to increase both the strength of contraction and the rate of contraction. So the role of catecholamine in triggering arrhythmias in structurally normal artery has been well documented. However, in individuals with CPVT, the mutation in the ranodin 2 gene leads to abnormal calcium release from the sarcoplasmic reticulum. So especially that is during exertion, that results in spontaneous calcium release. So there's aberrant release of calcium. So this leads to an initiation of a trigger activity. So even if, sorry, can I go back? So even if at this point, there is still repolarization going on, because of the abnormality in the mutation of that gene for those individuals, even in the midst of repolarization, there is flooding because of the abnormality because of the genetic mutation. So they are prone to sensitivity in the adrenergic stimulation during exercise. So that will lead to the flooding of calcium. So in the face of repolarization, they may still depolarization is trigger, and that will give rise to arrhythmia. So the is predominantly caused by mutation in that, as we have said, 60%. In addition, the calsequitrin gene is also implicated. I've mentioned the other genes initially. So the role of this gene has been, as explained, is that the mutation causes an increased open probability of the ranodin receptor, causing the flooding of calcium intracellularly, so which can trigger early or delay after depolarization. So that will lead to arrhythmias. So we have explained that for the receptors, but the calsequitrin is a calcium binding protein. So it's like, we can use the word chelate calcium. So it binds into calcium, making the availability, making calcium unavailable in the sarcoplasmic reticulum. So it plays a very, very important role in the storage of calcium. But mutation of this will lead to the reduced buffering capacity. So that would lead to the dysregulation of calcium release. So that also predisposed to arrhythmias. Okay, we've explained this already. So though we've explained the mechanism, the abnormal calcium handling leading to the to ventricular arrhythmias in this patient. So moreover, the role of reactive oxygen species in CPVT has been also noted. Oxidative stress can further exacerbate the ranodin 2 dysfunction and promote arrhythmogenic calcium wave. Increased mitochondrial reactive oxygen species level has been observed also in models. So the dysregulation of calcium handling can lead to impaired relaxation of the myocardium, contributing to diastolic dysfunction and further increasing the risk for arrhythmias. The clinical features, the important clinical features is that first, it's more common in children and adolescents, and it occurs the arrhythmias occurs during physical exertion or emotional stress. The clinical presentation is characterized by a range of symptoms, but syncope is the most prevalent. And there's a transient loss of consciousness. And also, in fact, in some patients, seizure have been recorded. In severe cases, they present with sudden cardiac arrest. Young athletes may attribute their symptoms. This is another reason why the diagnosis is missed. Some young athletes may attribute their symptoms to just fatigue and stress. And but the hallmark is the occurrence of adrenergic induced polymorphic ventricular tachycardia, which can lead to syncope or sudden cardiac death. The mean age of onset is 7 to 12, although some cases may present later in life. Okay, I think I've mentioned most of what is contained here. The diagnosis of catecholaminergic polymorphic ventricular tachycardia is hinged on this clinical history, a very good clinical history, very important, because in most patients you may see recurrence of syncope and associated with either exertion or emotional stress. Then ECG, stress ECG imaging, and that we'll discuss that. So, as I've said, the syncope palpitation during physical exertion is from history. So, when they are at rest, most times the ECG appears normal. So, it's during exercise stress, a patient may exhibit bidirectional or polymorphic ventricular tachycardia, which is key to the diagnostic feature of CPVT. The absence of arrhythmias at rest, coupled with the emergence of these arrhythmias during stress, is particularly indicative of that. Genetic testing play a huge role and is pivotal in diagnosis where these services are available. The importance of this, it's very important to distinguish this from other arrhythmias, distinguishing CPVT from other arrhythmogenic disorders such as long QT syndrome. We saw that yesterday. The arrhythmogenic right ventricular dysplasia is crucial because the management of these conditions are distinct. The clinical history is instrumental in the differentiation. For instance, patients with CPVT, they typically experience arrhythmias mainly triggered by adrenergic stimulus, while those with long QT may present with prolonged QT intervals and syncope unrelated, usually unrelated to exertion. ECG finding further aid in this distinguishing between them. In patients with CPVT, the ECG during exercise testing may show specific pattern of ventricular arrhythmias that differs from those observed in long QT or the arrhythmogenic right ventricular dysplasia. For example, why patients with long QT may exhibit early after depolarization, leading to toxic the point is CPVT is characterized by delay after depolarization and trigger activity. So the clinical presentation of CPVT also will help from the history. Some patients, they have experienced multiple syncopal episode before the definitive diagnosis. So in history, you may be hearing of several episodes of syncopal attack in the past, or even a seizure-like presentation, but mostly related to exertion or emotional stress. The ECG finding also, we've discussed that bidirectional. So you have QT intervals that are alternating in morphology. Then it's also important when it's absent at rest. Then we know the appearance of polymorphic ventricular arrhythmias during stress tests gives that out, as discussed earlier. We've discussed about exercise stress testing and genetics. So the role of genetics play an important role because even for patients that have been diagnosed, for other family members that are asymptomatic, this will help in screening and taking the appropriate step to prevent untoward complications. The treatment, it involves pharmacological, surgical, and device treatment. The pharmacological involves the pharmacological intervention with beta blocker, be it in first line, and um, the beta blockers function by blocking that adrenergic receptor, thereby reducing the effect of catecholamines. The efficacy of beta blocker has been well documented, but nadolol had been particularly favored because it has a long half-life and sustained action. Despite their widespread use, that is of beta blockers, approximately 30% of patients may experience breakthrough arrhythmias while on beta blocker. This necessitates the exploration of additional therapeutic options. So in such cases, anti-arrhythmic agents like fecina can be introduced as adjunct. Adjunct acts primarily by inhibiting the sodium channel, which help to stabilize the calcium membrane and prevent abnormal calcium release associated with CPVT. So flecainide the mechanism is particularly relevant in CPVT as it targets the underlying pathophysiology, that it has been shown to inhibit the ranodin 2 channels, thus preventing the calcium-induced calcium release, as we mentioned earlier. So there are indications for implantable cardiovascular defibrillators in this patient for the use of device. So it's indicated for those at high risk for life-threatening arrhythmia. So in patients with CPVT, ICD is particularly beneficial for those who do not respond adequately to beta blockers, which is the first line of management. Then the age at which symptoms manifest can also influence the timing of the ICD implantation. Younger patients diagnosed with CPVT are often at higher risk of sudden cardiac death, so they may have ICD indicated. The decision to implant should be based on comprehensive assessment, history, and also the frequency and the severity of the arrhythmic events. They are very important to decide on device therapy. But the effectiveness, there are several schools of thought in the use of device in CPVT, that is ICDs. There's careful programming of the ICD is essential, as inappropriate shock can trigger further arrhythmias due to catecholamines release, potentially leading to a cycle of arrhythmias, leading to ventricular storm. So some reports indicate that the use of ICD is controversial because of the fear that an ICD shock will initiate a vicious cycle of adrenergic input. Furthermore, young patients will tend to have higher risk of arrhythmia. So it makes younger patients presenting with repeated symptoms, they are more likely to have an ICD implanted. Another option is a surgical option, the left calcium sympathetic denervation. Left cardiac sympathetic denervation, I think this was mentioned yesterday in the long QT discussion. So the surgical removal of the sympathetic nerve that innervates the heart, thereby. So once you remove the sympathetic nerve innervating the heart, you exclude the tendency for adrenergic stimulation that will precipitate the arrhythmia. So it's minimally invasive, video-assisted thoracoscopic surgery, and is a viable option for also young patients, provided a risk to benefit ratio. is considered. The procedure is generally well tolerated, and studies have reported positive outcome in terms of overall patient satisfaction. The long-term outcome for CPVD can be there if left untreated. Also remember that the symptoms may be missed. In fact, some patients may be considered as patients with seizure disorders, because whenever they're having those adrenergic episode or emotional episode, they may have seizure-like symptoms. So outcomes for patients not without diagnosis and left untreated is usually there, but study indicate that untreated CPVT can lead to mortality rate of 30 to 50% by the age of 40, primarily due to cardiac arrest. A multicenter study highlighted that patients who receive appropriate treatment, including beta blockers and ICDs, had significantly lower incidence of arrhythmic event compared to those who do not receive timely intervention. The mortality, we've mentioned that 30 to 50% for untreated cases. Timely intervention is critical in mitigating these risks, like the risk of sudden cardiac death. The factors influencing prognosis, several factors, but most importantly, the age of diagnosis is very important. So the younger the age, also and also considering the severity, so that also put in perspective the use of device therapy. Also, the genetic variant is being shown that those with the ranodin 2 receptors mutation, they present with more severe symptoms. So those are factors that influences the prognosis. Quality of life, yes, the individual diagnosed with CPVD, they are often advised to avoid strenuous activities because that will precipitate the episode, particularly those that can provoke adrenergic stimulation, such as competitive sport or high-intensity exercise. The restriction on physical activity can significantly affect the lifestyle of individuals with CPVT, particularly in longer age. So this may have implication on the psychological health of patients, especially if these are adults that are active in sports. This may have might affect their psychology, restricting their daily activity. Recent researches have underscored the potential of gene therapy. So basically, because it's a genetic disease, so efforts are ongoing for innovative strategy for gene transfer of engineered calmodulin. There are others like pluripotent stem cell derived cardiomyocytes. Also is being looked at as a pivotal tool in personalizing CPVT treatment. There are other notable strategy. There's another one, the adenosine-associated virus vectors to deliver therapeutic gene directly to the cardiac tissue. There are other advances looking at genomic and editing the genome of affected patients. Research has also focused on the role of calcium handling protein in CBVT pathophysiology. For instance, studies have shown that stabilizer cell gene therapy, which involve engineering non-arrhythmogenic cell to suppress the activity of the arrhythmogenic cell, may provide novel treatment in this regard. So in parallel to this effort, also more pharmacological effort is ongoing to identify new agents that may modulate cardiac angiogram. And so recent investigation is looking at drugs like ivabradine and flecainide. We've mentioned that but their combination to give a mix, their combination yielded mixed result, necessitating further studies to clarify their roles in CPVT. Okay, I think this is the end of the presentation. I just copied one of a case presentation from the National Center for Biotechnology Information. Just looking at a scenario that was painted there, a 16-year-old who had suffered from recurrent episode of syncope triggered by physical exertion, was said to be brought into the hospital after undergoing defibrillation at the local emergency department. He had lost consciousness at school during a volleyball test that was also emotionally stressful. Paramedic found him pulseless and started cardiopulmonary resuscitation. An initial ECG at the local emergency department revealed ventricular arrhythmias. Although this arrhythmias was converted to sinus rhythm after defibrillation, the patient was stuporous and had repeated episodes of non-sustained ventricular tachycardia. After referral to the hospital, ECG monitoring in the emergency department and intensive care unit showed intermittent non-sustained VT and bidirectional VT. So the important thing to look at this slide before we go is the 16-year-old young boy, and it had there have been recurrent episodes. So you have a young man having recurrent episode of syncopal attack. This should be considered. So this was the ECG that was done showing bidirectional ventricular tachycardia as when it was done. Then you have, this was the baseline ECG compared to this when he was having those episodes. Then this was the ECG they captured while he was having exercise stress test, and so we could see some non-sustained ventricular bijamming. Sorry, ventricular bijamming. Sorry. So this is just the part of the history is on the slide. So the patient became agitated, but later he had, let's just look at the treatment. So later a genetic study was done, and the ranodin receptor 2 mutation was noted. Then he was given appropriate treatment, and thereafter discharge. Atenolol was used in that case, and he was later discharged. The second scenario here, also a young man also having emotional events and went into cardiac arrest. The summary of the presentation is for catecholaminergic polymorphic ventricular tachycardia. What we look at for is whenever we see a young is more common in male, so but is also recorded in females. A young person presenting with recurrent history of syncope or either seizure-like presentation is very important to have a full cardiac evaluation to ensure that this is ruled out. In our environment in which genetic studies may not be available, so the place of history taking, ECG, baseline ECG, and also doing the ECG, the exercise stress test will be very important in the diagnosis of such patients. Thank you very much.
Okay, thank you so much, Dr. Jeremiah, for that concise and brilliant presentation. Okay, so the floor is open to questions and contributions.
Hello, Jeremiah. Thank you very much.
Thank you, sir.
I don't know, because even though that the two case scenario you gave us were all in their third decades, because given the age now, the clinical picture can actually fit into angina that progressed with that got complicated with the arrhythmias. So, what is the age? Because I didn't see when maybe I missed it when you presented the age distribution of this illness. Is it commoner in the 20s or in the teens? So about what age really? Maybe that's the only distinguishing factor. What is the age distribution exactly? That's question number one. Question number two, in the surgical management where we have cardiac denervation, what is you have an idea what the response is like when these patients are under stress? Say if they want to do an exercise, for example, since the heart has been denervated, what is usually the response of the heart? Because it means that the heart cannot respond again to catecholamine stimulation, physiological catecholamine stimulation. So could that be part of the adverse effect, or does the heart compensate anyhow in the physiological process? Those are just two concerns. Thank you.
Thank you. Okay, thank you, sir, for the question. For the number one question, talking about the age distribution. When we're looking at the epidemiology, we looked at it being mostly in the young individual. Then they talk particularly in children and adolescents. So
that's wonderful.
Yeah. So and the median age of onset is around 10 years of age.
Oh, thank you. Thank you.
Then for the denervation, the surgical option, I didn't come across that, but I just know that for denervated heart, I think for after having such a procedure, I think the futures will be for that of the denervated heart, knowing that the resting membrane the resting heart rate for denervated heart will be higher than normal. But I didn't really come across looking at the prognosis or the response to that, especially in that. Maybe I'll check that and add to the slide.
Thank you. Thank you.
Yeah. Hello.
Yes, sir.
Yeah, and just to contribute to the question that Cyril asked. So even people who get heart transplant, they have a denervated heart because you're not able to reconnect the nerves on the transplanted heart. So like you rightly mentioned, because normally at rest is the parasympathetic or the vagal tone that predominates, so they will have a higher resting heart rate compared to normal people. In terms of their response to exercise, so what they will lose is the early response to exercise. Because when someone starts to exercise, the first stimulus to increase the heart rate commensurate to the level of exertion comes through the sympathetic activation. Okay, so if they are denervated, they won't have that. But however, as they continue to exercise, remember the noradrenaline can be secreted also from the adrenal medulla in an endocrine fashion. So later on, at a later point in the exercise, noradrenaline will be secreted from the adrenal medulla and then transported via the circulation to the heart, and then the heart rate can now pick up to meet the demand of the exercise. So the response will be late compared to someone with a heart that has not been denervated. Okay. I just want to ask, I don't know if I missed that portion of are there any peculiar finding on the ECG for this patient when they are not having the VT? Are there any peculiar things that you see on the ECG? And then when you put them on the treadmill to stress them, what exactly are you looking for? Are you going to, do you want to induce the VT and look at it and see the bidirectional VT to make the diagnosis, or you can make the diagnosis from other findings apart from triggering a VT in the patient?
Thank you, sir. Okay, let me start with the last question. For the exercise stress test, what I came across was they are monitored during the exercise stress test. So they are monitored if there's development of the VT. Yes, the exercise is stopped, that diagnosis is made. But however, looking at the symptoms of those patients too, if like they are having symptoms suggestive of like syncope, so that may also, especially when they are at rest, they were normal and now on exercise having that. But the important factor I came across was that there will be presence of this ventricular tachycardia during exercise, so that we pinch the diagnosis. I didn't really they didn't really emphasize in my sources, they didn't really emphasize looking at other features though. Then for the ECG at rest, from what I saw, most times the ECG at rest appears normal. In fact, they mentioned that is why the diagnosis is missed on most occasions. I didn't really come across any distinguishing features for those having, for CPVT, having a particular feature for an ECG at rest. Thank you.
Okay, thank you very much.
Okay, so thank you so much,